On the behalf of Indian Society of Critical Care Medicine, I welcome you all to this next session of the webinar, which is Preparedness for Third Wave. And this is talking about the resource management for third wave. So first of all, it's my always been a honor to introduce my chairman, Dr. Yatin Mehta, who is the chairman of Institute of Anesthesia and Critical Care, Medanta, the Medicity. He is the past president of Indian Society of Critical Care Medicine. Along with him, Professor J.V. Peter, he is the director of Christian Medical College at Vellore. Dr. Rahul Pandit, director Critical Care, Fortis Hospital, Mumbai. He is one of the member of the National Task Force of the Honorable Supreme Court, which appointed for National Task Force. Professor J.V. Peter is also member of the same task force. Then Professor Ashish Bhalla, he is in the Department of Internal Medicine at PGI Chandigarh. Then Dr. Jose Chacko, he is consultant Narayana Health Institute at Bangalore. Dr. Pratibha Dilip is yet to join. She'll be joining in 2-3 minutes. She is HOD of Critical Care Medicine and chairperson of HICC, Zydus Hospital, Ahmedabad. Dr. Monica Gulati Kansal, she is supervisor of training, CICM, Australia and New Zealand, and consultant intensive care medicine at Nek Teng Phong Hospital, Singapore. I'm sorry if I have pronounced little wrong. Then Dr.
Tongue twister.
Then Dr. Vikas Ranjan Ray, he is Associate Professor, Department of Anesthesiology at All India Institute of Medical Sciences, New Delhi. And our young dynamic President-elect, Dr. Rajesh Mishra. To moderate today's session is Dr. Subhal Dikshit. He is one of our past president, past chancellor of ISCCM, and he is director of ICU at Sanjeevan Hospital, Pune. Without wasting much time, it's over to you, Dr. Dikshit.
Thank you, Dr. Deepak Govil, the president of the ISCCM, and thank you, Rajesh and ISCCM, for requesting me to moderate today's session of a very important topic on resource management and how one should prepare yourself for the third wave of the COVID pandemic, especially when India has been hit after the first wave last year and the second wave just about a few months ago. So definitely the third wave is around the corner. There have been lots of ifs and buts. There have been discussion about how fast the third wave will come in. The virus has undergone a mutation with the Delta variant, the Delta plus variant, with the vaccination cropping up. Here in India, we have reached about 10% to 12% of the vaccination. Of course, where Dr. Monica is sitting, I'm sure they must have almost achieved about 90% of vaccination. But this is where we stand, and let us start the ball rolling at how we should keep ourselves abreast and how we should be on the tip of our toes so that we can reduce the morbidity, mortality, and definitely avoid the panic and the havocs what we face in India, especially during the second wave, as far as certain drugs or as far as certain oxygen problems are also concerned. So let's start the first question rolling and the ball rolling with Dr. J.V. Peter, who is the director of Christian Medical College. I would like Dr. Peter, sir, to tell us about that there have been a lot of mathematical models, there have been a lot of prediction models and to prepare for the third wave. So what do you think? Are these models really helpful, or are these models just a part of a nomenclature for discussion purpose? So what is your take on such kind of models and how reliable it is?
First of all, thank you for this opportunity to make this, to be part of this very important webinar. I want to look at prediction models in 3 categories. First is, what are the assumptions, what are the problems, and how we move forward. I've jotted down some points so that I can be clear and crisp. Yes. First is, these models make some assumptions. You look back in order to look ahead. It employs a certain law called the law of moving averages. It looks at the slope of the curve and extrapolates. Now, what are the major problems with these models? There is a lag time. As we saw in the second wave, these models were not able to give us an early prediction that there will be a huge spike.
Peter, sir, you are mute. Peter, sir, you are mute. Yes.
Yes. The first problem, as I said, is the lag in these prediction models, as we found in the second wave. The second is that these predictions are less accurate when you look at the length of presentations. So for short-term modeling, it's reasonably accurate, but in the longer term, it's less accurate. Third factor is that the simple prediction models do not fully factor in the susceptible population. Fourthly, global, that is national and state level models are less accurate than more regional models. We very clearly looked at the pattern or the dynamics or the transmission dynamics during the first wave and the second wave. And clearly there was a shift of the pandemic from zone to zone and region to region. And so I think we should stop focusing on national prediction models, but more regional prediction models. And the last problem with the models is it is even more complex now that there is vaccination and past infection. So how do we move forward? I think people who are experts in infectious disease modeling need to be involved because we need to factor in several things when we do the modeling. First is, what is the susceptible population? We have data now that suggests that if you've had 2 doses of vaccination, there is 60% protection against infection and over 90% protection against serious illness. We also have some data from our institution that if you have had a prior infection with COVID, there is a 97% protection for reinfection, even with the Delta strain. We also have seroprevalence data, we have heat maps, and I feel that we should generate regional prediction models. Now, all these models are not going to help if we violate all the norms of wearing masks and social distancing. So to summarize, prediction models have a role. In our own district, we were able to actually plan how we need to ramp up services using these prediction models. They need to be done every week and updated. There is a lag period and several factors need to be taken into consideration. So I'll pause here and I'm happy to answer any other questions.
Yes, thank you, Dr. Peter. Now, regarding this, do you think that the prediction models comparatively can fail, or they have gone vis-a-vis with the numbers what we have developed in India? The prediction model initially, like for example, just for discussion purpose, the prediction model initially predicted that the COVID in the world would end in March 2020, 2021. So do you think that such models will be really helpful, and can it really help us to predict when COVID will end, or it will go vis-a-vis with the vaccination, in hand with the vaccination process?
So I think we are in a better position to reasonably predict when it could end. And as I said, there are 3 factors that you put into these prediction models. One is, what is the seroprevalence data for that region? For example, in our district, 30% have seroconverted even before the second wave. Second, you factor in vaccination. That's another 20%. So you are looking at a 50% roughly susceptible population. And I'm sure we can factor this in.
And they don't have any symptoms.
And we can have reasonably good prediction models in the future.
Okay, thank you. Rahul, just one sec, you are a part of the Maharashtra Task Force and you're also a part of the national as well as the of the Supreme Court. Do you think at the government level, does the government really use these prediction models?
So thank you very much for having me here on this important webinar. This is Subhal and ISCCM. So as Dr. Peter just mentioned, me and he have been actually extensively looking at these models on the national level, and we've had several of these modelers come and do presentations to us. Coming to the crust of it, I think he's actually mentioned very nicely that
Yes.
you need to come to a regional level, nothing else. You need to basically regionalize these modeling things. If I would take up the example of our state, Maharashtra, with the Delta plus variant and 7 districts of concern, we were actually able to have a reasonable amount of prediction with these 7 districts. We got the modelers, we actually had a bit of a understanding of what are we looking at, and we ring fenced these districts. The 7 districts were ring fenced to a reasonable way. In fact, one of the talukas was ring fenced just at the taluka level where the maximum number of Delta plus variants came across. And we were able to probably curb it down because we haven't had any, we are doing around 100 genome samplings from each district in Maharashtra every week. And from the districts of concern, the samples are almost to the tune of 700 or 800 per week. And we have been able to control it to a nicer way right now. But as Dr. Peter has mentioned, when you look at the vaccination factor, vaccination penetration in it, factor the positivity penetration in it, I think the models will become incredibly difficult to interpret at a larger scale. I think we'll have to come to this micro geographical area modeling and have to plan accordingly.
Okay, thank you, Rahul. That's a very nice way. Thank you, Dr. Peter also. Dr. Dilip, Dr. Pratibha Dilip has joined.
No, sir.
Dr. Pratibha Dilip, madam. Okay, I'll just move on to the next question now to Dr. Yatin Mehta, who is the past president and chairman of Medanta. I would like to mix this question together for Dr. Mehta. Now that, hello. Yeah. Mehta sir, we know that large number of people, especially into the urban areas, were affected during the first wave and the second wave, and gradually then even the migrant workers then started going back to their respective rural areas. Now that the wave has now started affecting and also spreading into the rural parts of the country, how will you manage those, and what kind of training programs, and how will you see that those areas are less infected? Do you have any plan? Can you tell us any plan how you can do it? And apart from that, there's another question for you too, that once you have put that into plan, you have already been the first part where you looked after the Italians in the first wave. And then how will you plan? Is there something different plan you have put forth in your hospital, or would you recommend to other hospitals in the country for the third wave, how to prepare?
See, I'll come to the second part of your question first, because
Okay,
I'm not really a rural health expert, but I work in a tertiary care hospital, and we got the full heat of the second wave when it exploded. So what I think one needs to do is what Dr. Peter talked about, these prediction models can be utilized to actually predict how much your institution or your area is likely to get affected, and how many beds are you supposed to have in the hospital as well as in the intensive care unit. What percentage of those patients are likely to be in critical state where they require high-end oxygen therapy. Reinvent the wheel, we have gone through 2 waves already, and how to quickly increase your infrastructure. The physical structure is limited. How to increase the availability of oxygen beds, how to increase the availability of ventilated beds, and how to increase the availability of high-end oxygen therapy beds. So that is easily doable. You know how many patients you're going to get. So you need to plan a physical infrastructure. Obviously, you can't create new hospitals very soon, but within the structure which you have, so plan your physical structure, plan your manpower accordingly, because how are you going to man those ICUs? Overnight, you cannot quadruple your intensive trained physicians. And the third problem which we faced in the second wave was the supply chain. We ran out of, the whole country was gasping for oxygen. So that was another thing which we had to struggle, how to plan your oxygen requirements. So we cut down on HFNC usages. You have oxygen compressors for patients in the wards, so that your oxygen requirement in the wards goes down. So all those things need to be planned adequately. So the infrastructure wise, I think you need to have the plan your resources better, human resources as well as the physical resources. Suppose you've got 50 ventilators and you've got 200 or 100 beds. How are you going to allot it to the different areas of the hospitals? Beginning from triaging, it becomes very important that your patients are triaged adequately from the beginning. The moment they enter the hospital, you should have a clear-cut plan where your patients are going to move. That means your hospital, which is functioning, which is not a totally COVID dedicated hospital, has to be divided into red, orange, and green zones. And the movement of the patients doesn't need to be mixed also. And same needs to be planned for your staff also. So you can anticipate what trouble you are going to get into and how are you going to suddenly increase. Now, some government agencies have said train intensive care physicians in a 6-hour course. You cannot do that. It will be stupidity and it will be wastage of your resources. Instead of those people working in the ICU, they'll be trying to train these guys who are now not trainable at all. So you need to utilize that some people, even if they are specialists, can work on the floors. They can do the other works, the non-medical work, which is not required in the ICU. But ICU trained nurses and ICU trained physicians have to be accordingly utilized. And that also means the patients in the emergency, there also you require patients who are able to do interventional procedures and things like that. So plan your staff accordingly. starting from the residents, we pulled in all the patients, all the doctors, consultants also, according to how much training they had. Like an orthopedic surgeon would be useless in a critical care. I mean, but he can fill in the forms and he can talk to the families. Just for the counseling and all that, you can utilize them. They can be outside, and inside should be different people and adequately supervised. So you can have anesthesia people who are able to intubate, but some critical care guy or senior anesthetist supervising them. So I think this requires a lot of advanced planning in terms of the movement of the patients, in terms of different grading your zones and your staffing, how you're going to get them off, and when the staff falls sick, how are you going to, how long are they going to be out of the circulation, and when they can come back? All those things need to be modified according to the requirement and according to the infrastructure which you already have. So this is a little complicated, but we all need to plan in advance. We, as a nation, we are very poor at future planning. We are very good at firefighting. So we need to change our culture. Singapore dealt it with so well. I was going through an article by Dr. Go, and although it is only a 10 million, 10 lakh, 1 million population, that doesn't matter. If you compare it with Bombay or say in another city like Pune, how well Singapore controlled it compared to any other city in Delhi. I mean, it is advanced planning and it is discipline of the people, which we were lacking. We probably will be doing better at the third wave than the second wave.
Yeah, thank you, Mehta sir. Monica, like you see, you're in Singapore and you said that the cases are almost less there. So how well is your hospital prepared in case if you have a third wave? Can you just enumerate the points in short?
Yeah, so I mean, I can say from last year, firstly, in Singapore, so there are two aspects of this question. One is, of course, the planning of the government, and the other is the planning of the hospital. But I just want to say one or two words of the planning of the government, because that's very important to keep the country together. One part of it is that there is only one centralized authority in Singapore, if you were to compare it to a state, and that's the National Institute of Infectious Diseases, which has set out guidelines starting from surveillance to treatment to management. And the drugs as well are controlled by them. That means which drug to use what. And of course, there are different hospitals and there is individualized treatment, but we generally have compliance to those protocols. So in the hospital, some of the things which Dr. Yatin Mehta mentioned, that's what we did. In the hospital, there was a centralized authority. Again, the infectious disease department took that responsibility to create guidelines. And they were dynamic because as data was evolving, when to do swabs, how frequently to do swabs, when to do de-isolation, all that was regularly updated and was sent to all departments. So that was one aspect of it. Clear pathways were established starting from the emergency. And again, as you said, the color zone differentiation of a hospital. Similarly, we divided our hospital wards into dirty wards, and the whole like there are 3 buildings and we divided them and we changed the structure. Isolation wards were created. Of course, I have to say that after the SARS pandemic, the government invested in this hospital. This hospital is a hospital which just opened in 2016. It's a 700-bedded hospital, and I work in a combined integrated HTU and ICU. It's 34-bedded, but we have 70 rooms, and they planned this in after SARS. And so the infrastructure is in place. Negative pressure rooms are there. There were ventilators. What, of course, was lacking was how would we escalate in terms of human manpower? We also have a certain group of people who work in a roster. So what we did, as Dr. Mehta was suggesting, that we utilized the manpower from departments which are closely linked to intensive care, that is anesthesia and respiratory medicine. Those were the first 2 departments where people came from, and we utilized them, and we utilized the course of basic from Hong Kong, which was in terms of training also, we couldn't meet and do physical training sessions, so we did the e-basic course. And again, as Dr. Mehta said, I agree that of course, procedures can only be done by the anesthetist, but there are many actions which other junior doctors can perform. So this was the part of planning of manpower through training, which we performed we did perform training, but we did it through more through a bit of skill stations, of course, hands-on, but more so through e-lectures. And we had people coming from other departments. And the rest of it, as I said, there was clear workflows established about who will be swabbed, where will the patient go, how will the fumigation happen, security moved from the lift. So, because of the clear pathways, I think there was very good clarity. And in terms of escalation of care, we have another hospital, which is the ECMO center, so which is 20 minutes away. Singapore is so small. So we already were pre-COVID also always transferring patients. So those pathways were able to be utilized because they were already established. Part of it was already established, but I think part of it was that there is a central authority who makes the decision and there's not much confusion created. I think that's the basis of the hospital management.
Okay.
So I wouldn't take more time. Thank you.
Thank you. Welcome, Dr. Pratibha Dilip. Madam, you're the director at the Zydus Hospital in Ahmedabad, and you look after various surrounding peripheral rural parts which are connected to as a tertiary care center. How well and how will you try to educate people, especially to avoid the spread of COVID into these rural areas or the remote areas which are not being infected as of now?
A bit difficult task, but I think, in my opinion, we should hold meetings say social medium can be used, or television can be used, because television is something which is there in even the smallest, remotest town also, remotest village also, and there are people who are seeing it. Even I would say on radio, the Vividh Bharati station is something which goes to smallest town. Our FM other channels don't reach there, but radio channels are there where these questions can be answered. And these sarpanches of all these, like I stay in slightly, I would say in a village. I would say I'm about 12 kilometers away from Zydus Hospital, and which is a small town kind of a thing. So there I saw our sarpanch holding multiple meetings, telling people to, motivating them for going for vaccination, and holding the youth, making those people understand the importance of their vaccination. So I think this is a very important thing where we doctors and even our juniors can help. They can hold various meetings, they can answer their questions, and kind of prepare them for at least mild and moderate cases, how to handle them. That can very well be taught to them, and at least identifying the problem areas, and immediately those patients can be shifted to bigger centers. And the schools and community halls can be prepared for taking care of lesser sick patients. There was one suggestion from one of my my relatives, actually a distant relative, when we said that we don't have people who are taking care of these people. They said their family had suffered from COVID, so she said, I am willing to come and help them if there is nobody to take care of those people. So like that, we can now probably divide the population in two groups: somebody who has had COVID and somebody who has not had COVID.
Absolutely.
So those who have had COVID should give a helping hand to the medical team.
Yes.
And believe me, public, if we talk to them, they're more than willing to offer a helping hand. So I think we should meet them. We should talk to them that, look, we need your help, because doctors alone or nurses alone will not be able to handle this. If it comes in the scale what it was in the second wave, or probably I am expecting it to be bigger than that. So we'll not be able to handle it all by ourselves. We have to have some help coming from the community.
Yes, thank you, madam. Rahul, I'll just pass the extension of the question to you. You've been into the state level also management. So how will you prepare the state, especially for the third wave? So what has been the current plan for the state, especially at the local state level and also at the national level, into different parts of the states which are really not that well equipped like other states?
Subal, there are three aspects of this training which we are the preparedness which we are doing. The first aspect is improving the infrastructure and availability of resource management. So we've had a significant amount of ramp up in the infrastructure at the state level, number of field hospitals have been built in Pune, Mumbai, Nagpur. Bigger hospitals have come up now. We just inaugurated a 1100, 1200 bedded another jumbo center in Mumbai. Pune, we building up another 2 centers, the ones which were dismantled now. Similar centers have been built up in Nagpur as well, so that we can actually have this beds available. Similarly, for the resource management in terms of oxygen, in terms of medication, the state has really planned up quite advancedly now. We actually will be having a significant amount of drugs available to us. The state has created a special budget for that. And
We'll
you know,
be
though I
discussing
am from
about
a
the
private
audits
sector,
later. So I would like Rahul to discuss mainly focus
So I
on
will,
education part.
yes,
the
I'm
report.
coming to that. The third part is educating every. So the Maharashtra has been quite fortunate that we actually have a task force at every district. So the task force from the government, which is us, have been talking to them and creating a lot of awareness, teaching protocols, talking about handholding them, and creating in the intensive care resources are only limited. So creating electronic links with the ICU there in the periphery, so that we are able to actually handhold them directly in patient management. So these have been some of the highlights of the management of the preparedness for the third wave. And of course, I agree that we have to be actually prepared for at least 20 to 30% bigger wave than what we experienced in the second one. So Maharashtra had around 40 lakh cases positive when during the second wave, and now we are looking at around 50 to 60 lakh cases if at all they come across.
Okay. Did you think of considering a digital remote monitoring, especially from the advanced centers to the remote places? Do you think this will work, especially in the third wave? Like, for example, in a small village like Mulshi, and you are there. So will such kind of apps or such kind of digital media will be helpful? Rahul?
You have asked me, sorry, I missed the question. My internet connection just froze out.
Yeah, no, Rahul, my question is, now that we are looking into a digital world, do you think like you are sitting you are in Fortis Hospital or some other big consultant is in another hospital? Do you think that rural area should be monitored digitally by such bigger hospitals?
I think digital monitoring is the way to go ahead. No question about that. There is absolutely no question about it. You have to handhold them digitally. See, we are at least 5 times shorter the number of intensives required for this country. There is no way you'll be able to bridge this gap. So digital monitoring, the health is going to be the next big thing. And I think those who have already established that, many of the states have invested into that. So Telangana, for example, we are following what Telangana has extensively invested into it. And I think it's really going to reap benefits for them in the third wave, if at all it comes across.
And medical legal safety also has been given now by the Supreme Court.
Yes, absolutely.
Okay. So I think that's another way we should think of. So all hospitals should take care of small villages which are nearby, at least for remote monitoring into these patients. Okay, thank you, Rahul. Now, just moving on, we have heard from Dr. Mehta, Dr. Rahul, how the state and the predictive models really help us to plan the next course. Now, over to you, Dr. Jose Chakoki, especially like you're working in Narayan Rudhyalaya, a big hospital. Like the infrastructure-wise, how will you do the audit of your hospital? Like we think that the number of patients are going to go up. So how will your hospital, the number of beds, how do you think will you procure beds? What should be the quarantine facilities in it, home quarantine or plain, or how the lab testing should be arranged in case if they are not there? And how will you analyze the manpower of your hospital? You have dealt with the first wave and the second wave. Do you think it's enough to look after the third wave?
Thanks, Subal. Yes, we've learned the hard lessons from the first and the second waves. And among the important lessons that we learned were, first of all, to triage your patients. And depending on the severity of illness, allocate them to pre-specified areas. In fact, we had the luxury of having a dormitory-like accommodation, which would accommodate patients with a low level of severity of illness. And if required, we could provide oxygen to them as well. So that was level 1. And level 2, of course, were patients who required oxygen up to a certain limit. And this could be up to, say, 6 liters per minute, 8 liters per minute. And if they required more oxygen, then, of course, they would be moved to the ICU or similar areas. So we had a 3-level care. And as I mentioned, we had the luxury of plenty of bed space to accommodate these patients. So that was pretty much okay. And as I mentioned, I would underline the fact that triage is most important. You should ensure that the right patients get the right place to be accommodated. Those who are severely ill obviously will require hospitalized care. Those who are asymptomatic or with mild symptoms are better managed at home. And that is a very important lesson, I think, that everybody should probably learn from the first two waves, to make the best use of the facilities you have and not to crowd hospitals with patients who don't really need to be there. So depending on the magnitude of the surge, the number of beds allocated to each area would also need to be planned ahead of time. And this is, of course, going to be dynamic because the evolution of the number of cases will vary depending on the time lag. Initially, you will have mild symptoms, which progress to severe symptoms, and later on, there will be more patients who require intensive care. So you will need to plan accordingly. And this would entail meeting at the top level, including administrators from time to time, regularly, perhaps even on a daily basis, to keep track of the numbers and plan your bed capacity accordingly in the areas that you're earmarked for different levels of care. The second most important aspect is, of course, contact tracing, which is needless to emphasize, a very important strategy in reducing the transmission of COVID-19. Once a probable or a confirmed case is identified, individuals who've been in contact with the index case should be identified and instructed to quarantine to check further transmission. Super spreader events may be traced retrogradely through individual case investigation, and this is called as backward tracing, which we've been doing on a large scale, particularly during the second wave. And third, of course, as you mentioned, you need the workforce to carry out contact tracing, as also train people, train personnel to take care of the severely ill patients in hospital. As Dr. Mehta mentioned, you can't train them overnight. This is something that you need to look at, particularly when you plan long-term. We are right at the nadir of the second wave, so perhaps this is a time to plan for maybe a wave that is larger than the second wave, as we've seen from the experience of the US, for instance. Their third wave was by far much larger than the second wave. So that's something to keep in mind and be aware of and plan. I think we should plan for maybe at least 1.25 size of the second wave for a future possible third wave, even given the fact that we are vaccinating people on a large scale. A bit disappointing in some states, particularly overall, if you look at the Indian statistic, it's only about 15% of patients who had at least one dose, 15 to 20%. And those who had two doses is just about 5%, which probably is not enough in terms of offering immunity to the community at large. The third and most important thing is adequate level of testing. The RT-PCR testing as we stand today is perhaps not adequate because it takes pretty much 2 to 3 days for the reports to come, and that is definitely not the most optimal time period. Rapid antigen testing has been more in use, particularly in some states. It may be effective, but the false negativity is substantial and it may not be the most appropriate, I believe. And in fact, I have seen self-testing rapid antigen kits available these days, which may be helpful if you do repeated tests over several days, perhaps maybe comparable to RT-PCR. And then, of course, rapid RT-PCR is going to play an important role in rapidly identifying patients with high degree of sensitivity and specificity. As I understand, it's available at several airports. Perhaps we need to extend the use of rapid RT-PCR to several other clinical situations to be able to diagnose COVID-19 with precision and to ensure that we take appropriate precautions early enough. So that's, I think, the level of preparation we need to look at if at all we are going to face a third wave that is larger than the second wave that we encountered.
Yeah, thank you, sir. Thank you. Mehta, sir, one question for you. Like I've already told about, yes, the facilities, how the hospital is going to be prepared. This is mainly applicable into a bigger institute and you are working in one as a chairman of one of the most pioneer institutes of the country. But I would like us to tell you to tell all other doctors who are listening, who are planning to start up a hospital setup, how they should plan the ICU, what sort of equipments, which sort of ventilators they should have for the unit, especially to prepare for the third wave. We have got large number of array of ventilators, right, from PM Care to NOCA to all other different forms to even small NIV machines. So how you should have prepared a hospital for the third wave? That's more important. Syringe pumps, or what sort of equipment, how the ICU, whether they should have an oxygen bank or they should keep oxygen concentrators.
See, oxygen concentrators, Subal, will not take care in the intensive care unit. They'll work all right on the ward or in HDU up to 10 liters compressors, oxygen concentrators you can have. But otherwise for ICU, it really doesn't work. ICU, we used to use it when we were waiting for the HDU step down unit, and the patient has come down to 5-7 liters. We got some compressors as an emergency basis. We also bought, a lot of patients, we were using regular ventilators for NIV because that is what we had, because we ran out of NIV. So what we did is, on an emergency basis, we purchased a good number of non-invasive ventilators, because the utility can continue after the surge has gone. You can use it more on the floors. You can use it in the triaging and emergency areas. So you should buy equipment which can be utilized afterwards also when the pandemic declines. Also, it becomes important that if you cannot have a Mercedes, you can manage with a Maruti. So
Right.
Don't look for a high-end ventilator which has all the graphs and flow volume curves, and you need not have that. You should be able to have a ventilator which can give a high concentration of oxygen, which can preferably a turbine-based ventilator is better for a smaller hospital where you do not have necessarily compressed air. When you are designing a new hospital, I think in this situation, you all realize, in my ICUs, when we had designed Medanta, we had given two oxygen points on every ICU bed. So additional oxygen points or additional compressed air, does make sense, because you could put in more additional beds, which we did during this time. Between two beds, we put in one more bed, but it must have a suction and oxygen. So even if you have oxygen, not very high oxygen flow, you can put wire connectors and divide it into two, because there's no risk of contamination, because these are all positive cases. Right. Also, when we designed, what we did was that we divided each ICU into two. There was a door which was closed, which has separate air supply. So you can close down one area. So at one point of time, we used one half the ICU as a patients who were waiting for the COVID test results to come. Those days it used to take a little longer. And other half were patients who were already positive, with different staffing and different donning and doffing areas. So that also needs to be taken into consideration, that in future, this pandemic goes, some other disease will come. So where the donning and doffing has to be done. So you have to be clear how the movement is going to happen.
Right.
So we had a front and back to ICUs with two doors at different directions. So the lift would come and the patient would come only to a confirmed area, COVID positive area. It doesn't have to mix with other areas. So how those patients will move, and that area we dedicated the lifts only for this COVID or suspected cases, which were not used by the rest of the staff. Those floors were completely locked out for the other areas of the staff or the hospital. These were dedicated areas only meant for either staff or the supplies for the COVID area. So their dirty utility would go a particular way. It will not mix with the rest of the dirty utility of the hospital. So, and obviously no visitors were allowed during this. So in future, if you have it, it is a good idea to have some sort of a video conferencing facility where the patient's relatives can be communicated or shown the patient. So that also needs to be kept in mind when you plan your new ICU. Also have maybe a computer point, additional point for laptop connectivity on the bed. If the patient is not on a ventilator, he can easily communicate with his family, or so that these things need to be kept in mind. The air supply, have more negative pressure rooms when you are designing a new ICU for future reference. So negative pressure rooms can be converted to positive pressure rooms, but positive pressure room is not, you cannot convert to a negative pressure room. So have those facilities where you can convert to a negative pressure room. So with isolation facilities and closing down the other areas. So these things need to be taken into consideration. As you rightly said, the syringe pumps, again, syringe pumps occupy less space. So that also makes sense rather than having a proper infusion pumps where you require a dedicated IV sets also along with that. And if it doesn't match, it's a problem. So have a syringe pump which fits, every syringe can fit into it, not necessarily the syringe which is designed by that particular make. So these things need to be kept into mind when you are ordering new equipment or you are designing a new intensive care unit.
Absolutely. Thank you, Mehta sir. Another,
Well,
the
can I
same
just
question
add on one thing to it, Subhan? Is that all right?
is coming to you from the government perspective. You being the task force member in local state level, has the government planned anything?
Yes, government has planned a significant amount of things, Subal. I think most of the ICUs which have been now expanded in the state have been done under our guidance. So we all, I mean, all the task force members, we are from private institutes and I'm from Fortis. So similarly, the other people are there. So we've sort of brought it up to some form of a standard where it requires a lot of investment from the government, and which is a little bit of a process which takes time. So, I think the government is planning their best to try and bring across a standardization in intensive care. Medical colleges have been earmarked to have a hub and spoke referral centers being present up across the state. And that's how we are probably going to progress on towards the third wave. I just wanted to add on one thing what Mehta sir said, that, up until now, we were showing off our transplant ICUs, we were showing off our neuro ICUs. I think in the years to come, we will be now showing that the best ICU which we have is a respiratory ICU. We are going to have a state-of-art respiratory ICU. All the hospitals which are going to come up and build up anything new, it's going to be a state-of-art respiratory ICU, which will be able to cater to such pandemics or any infectious disease pandemic in future.
Okay, thank you, Rahul. Over to Dr. Peter, sir. Just one question. You've been the director of a huge medical institution. So my question to you is, it said that the third wave is likely to affect the pediatric population. You being the director of a huge institute, have you taken any precautions, or what sort of preparations have you kept in mind from the pediatric department?
So we are using a catchphrase called repurpose. It's not easy to create new infrastructure for pediatrics in a short period of time. So the mantra that we have put down is to say repurpose spaces, repurpose people, and repurpose equipment. What do we mean by that? There are spaces available. Of course, we'll have adults and children competing for the same spaces. But if we can refine or modify existing space to be able to accommodate children, that is one way we can handle things better. Second is repurpose people. There are adult intensivists who can be trained in pediatric intensive care. There are other physicians who can have a bridging course to be able to look after children. And that's the second area that we are focused on. The third is equipment. The key equipment will be ventilators, and many of the good ventilators can manage weights up to 5 kgs, and below 5 kgs is going to be a problem. But having contacted many of these companies, it's often only a software addition that can enable us to go down to lower weights. So this is a three-pronged strategy that we are suggesting to our pediatric team. And I think it's easy to remember and easy to focus on. Yes, additional spaces may be required. We also understand the challenges of managing children are going to be very different to that of adults. We would have to have a change in the strategy in terms of allowing one parent to stay and things like that. So this is the broad framework. There are task forces that are set up both at the institutional and the state level that are deliberating how to do this.
Okay, thank you, sir. Welcome, Dr. Ashish Bhalla. We definitely saw that, yes, the drug continuously kept on changing. Remdesivir was the drug of choice, then tocilizumab, itolizumab, bevacizumab, lot of methylene blues and all sort of drugs were used there. So how will you plan your unit, especially for doing the perspective audit, and how will you manage the inventory into such kind when you're preparing for the third wave as far as the drugs is concerned?
Yeah, Dr. Shubal, thank you. There are a couple of things which I wanted to touch before I go on to the drug. A couple of good news. Chandigarh, as somebody, I think Dr. Rahul said that, and even Dr. Peter said that we need to go to the local, setups, micromanagement, see what is the incidence of seropositivity or what has been the vaccination strategy in the area. I want to share just very, in a very small time with you. In Chandigarh, we conducted the serosurveillance for adults and for the children. And for the adults, the results are still not out, but for children, 69%. We have not been vaccinating children. 69% seropositivity. So if it means anything to us, 70% plus, this means that if we have exposure to whatever is the variant now, and if there is some kind of cross immunity, we may not end up seeing a lot of severe cases, even in unvaccinated individuals, in unvaccinated children. That's a good news. That's something which has come out from what we've learned just now. Just yesterday, that report was out. So that's what I wanted to share with you. If we have a very different variant, which is, Delta plus or Epsilon, and which has not been conferring any immunity, then we might end up with something different. Coming to your question about tocilizumab and remdesivir. So when we were faced with the problem this time, we were asked in the second wave, what is the requirement? You have to give a projected requirement. And we looked at what was our requirement last year in August and September. And we added 25% to that, and we gave that requirement. And we constituted a committee at an institute level where a demand for the remdesivir or tocilizumab, or for that matter in the later stage, even liposomal amphotericin, and now even for monoclonal antibodies is being raised. It is being sent by a WhatsApp note to one of the committees. They look at all the patient parameters and they prescribe. So if you have a centralized command, as Monica also said, centralized supply, pharmacy acquiring all the medications, you are rationally utilizing. There were people in the first phase who were giving tocilizumab 2 doses, 3 doses, people who were not even requiring, giving remdesivir for 10 days, beyond that, not requiring. With this, we have come to some rationalization. So I think a lesson which needs to be learned is that there has to be a centralized sourcing and centralized dispersal. Nothing wrong. I might feel bad that I'm an intensivist or I'm an ID specialist. And if I'm prescribing a medication for certain group of patients, how can someone, raise a question on that? There's no point. You should take it in a positive manner. That's what his job is. Convince him that you need it, we'll give it to you. We've learned that our monoclonal antibody usage has become far more rational at PGI because we had a limited supply and everyone wanted it. So when we start questioning that, why do you need it? What is the benefit to this particular group of patients? It becomes a little more rationalized. So that's something you can look at your data. Second thing, which I was really kind of impressed by Dr. Yatin Mehta's statement. We are very good at firefighting. Whenever there is a fire, we'll fight it very well. We're very poor at planning. This is the time God has given us that we need to look at what our requirements are. Let us plan for what is the drug requirement at the peak of the last surge, per 100 patients. And we take it up from there. And we can escalate our, inventory based on that. One problem which had come last time was with tocilizumab. It was not available. It was not available, or for liposomal amphotericin, it was not available at all. We went back to conventional liposomal amphotericin in patients where we could use it, and in hospitalized patients where we could monitor their electrolytes, monitor their creatinine, and use liposomal amphotericin in a better manner. So you always should have a backup plan. We are conducting a study on baricitinib, whether we'll be able to do away with TOSI demand if we use baricitinib upfront. We need to think out of the box. If we can't get tocilizumab, we can't give drugs which are not indicated. People have used all kinds of MABs. You know, anything which starts with or ends with MAB has been used.
Absolutely.
That doesn't mean that it should be used. You need to look at the alternatives. Can we give something upfront which would take away the need of tocilizumab at a later date? So that's where, that's how now we should be planning. But we should always, like they say, that trust in God, but lock your car. So you know, you trust that the third wave might be milder in Chandigarh because 69% or 70% of the pediatric population has already have shown seroconversion. But we can't stop there. We have a separate, in PGI, we are blessed that we have a separate pediatric center, which we have already activated. They have 100 beds with them working. They were taking up patients. They have ICUs, but they can be, you know, scaled up at any given moment. We can also, in our ICUs, we purchased 30, 40 ventilators, which can be used both for adults and for pediatric population. We have invested heavily in BiPAPs, which can be, you know, a bridge between the ventimask and between the ventilator. So these are the things where you need to, and they can be used at a later stage, because being a government institute, we have to give an account at the end of the day, where have we used that equipment which we had purchased. So like Dr. Mehta said, buy things, and Dr. Rahul Pandit also said, buy things which she can use later on also in the ER, in the on the floor. BiPAPs can easily be used. This time we have set up 2 oxygen plants, and all the hospitals in Chandigarh, not only PGI, all the hospitals in Chandigarh have set up an oxygen plant. So that's something which is good. Last time we kind of took the help of Chandi Mandir, which has 1,000 beds for soldiers. They opened up for us. They took up Chandigarh, having a large amount of people who are coming from the armed forces background. So all those patients were directed to them, and they were able to take a lot of our load. So these are the things which you have to think of, and you can plan in that manner. Centralized drug monitoring, centralized drug dispersal is, I think, the most important thing. And if you can have a centralized ICU bed dispersal, which is the Bombay model, I think that's something which we haven't done in Chandigarh, but could be thought of as one of the possibilities.
Yes. Thank you, Dr. Balla. Thank you on this. Over to Dr. Ray. You're working at AIMS, one of the pioneer institutes, and you're working in a huge setup where you have got good amount of coordination between the private sector as well as the government sectors. So how have the government plan, or how has your institute or you plan AIMS to coordinate it with the local hospitals in Delhi, that's the state level, and what should be the coordination between the other governments and the private sectors, especially for triaging, admission, shifting of patients? Dr. Ray?
Thank you, Dr. Dixon, and thank you, ISCCM, for giving me the opportunity to discuss about these issues. First of all, regarding the cooperation between the government and the central government and state level, it should be at least a cooperative federalism, rather than, unfortunately, in the last second wave, we see it's like especially in Delhi, competitive federalism, where everybody is compete for control of the jurisdiction or the attract the voters. So if you are planning for the third wave, the cooperation between the government and the state level should be at a same level. They should sit down and focus regarding the similar objective. And as Dr. Bhalla was telling, a centralized or the responsibility will be clear. Which one is giving the beds, which one is distributing the drugs, which one is allocating resources. So these should be focused objectives, so that if the third wave comes, is a bigger way or a larger way, we can manage those things. And also the policies and politics behind the vaccination, although a little bit thought out, they should be much more simplified, and there should not be any clumsiness or any clutter on which vaccine to get, where to get. So those things have to be sorted. Second things, as you told, between the cooperation between a government and private institute, which is vital for the goals of the government to be achieved, because without both them acting in a synchronized manner, these goals or to defeat the COVID-19 is impossible. Especially if it comes to private sectors or government sectors, the major thing that will be to bring up the critical setup in a research limited settings. Most of the things that we discuss are, most of people are in a better hospital with all the availabilities, or a tertiary care hospital, or in the cities or urban centers. But if you are planning for a larger wave, so we have to take care of the critical care situations, or the patients who are not in urban setup or smaller setups. So building of the critical care setups in a resource limited setting should be the priority, and private sector have a bigger role in these things. Coming to our institution, as whatever Dr. Mehta or Dr. Pandit said, those things we develop over the fast, and all the things are done in our institute, starting from planning till the point of receiving the patient to the lift, to the dedicated pathways, and everything was done. And many things we have planned, and we have suggested the government regarding the implementation from transport of the patient to oxygen policies. And in our setup, we basically have three setups. One is a hospital, which is a NCI cancer hospital, which is a 40 minutes drive from main hospital. That is mainly for dedicated for persons who require only for quarantine or isolation, and at least a little bit of oxygen therapy. And we have a dedicated and very efficient transport team with transport policies, with receiving and taking over proper notes. All are managed by the hospital administration with some dedicated BLS and ACLS trainers. And for transporting patients from there to trauma center, which is a dedicated COVID hospital. And in the peak of the pandemic also, we have in certain portion of the main building that is converted into COVID ICUs and those things. So regarding shifting patient from different hospital, because again there is some confusion regarding the centralized and state level hospital. We received many patients from different government organizations like army background, CRPF. All those patients came to us, and most of the state level patients are managed at the state hospital of the Delhi. So, and if you are planning for a third wave, so the coordination between those things are much more required, and a dedicated on a clear responsibility of the which thing is responsible. Suppose, as Dr. Bhalla was telling, a centralized bed allocation or centralized drug administration, centralized oxygen things, or a dedicated team that is looking after those things are important, and somebody should be responsible for those things. Rather, current scenario is much more clutter, and that lead to all the panic, and the story of Delhi or most of the cities in India are heart wrenching. Let's say.
Thank you, Dr. Ray. Over to you, Monica. Like we saw that, yes, communication is very important now into these patients. And how have you been? And we also saw that digital waste is the way to monitor patients. So how do you monitor patients from your hospitals as a tertiary care hospitals into smaller areas? Do you have any model in which how do you monitor them?
Well, in Singapore, particularly, I wouldn't be because it's such a small place. So we don't really have a rural hospital. But but I work with a company in India, which is a tele ICU company. So I won't name that company; it won't be appropriate. But based on that, and based on my previous experience in Australia, where I was trained, the whole retrieval system is based on a structured, on an organization where you have a communication pathway with clear channels and clear escalation flow chart. So there are various ways of looking at it. A simple retrieval system, in which one hospital is connected to another hospital through just phone calls and video systems, or which is just giving advice. That could be the first way of communication, the basic level of communication. Second tier of communication could be that I not only give advice, but I accept your patient. That means you are a district hospital, I am Fortis, or let's say I'm the medical college of the state. You tell me I can only manage a patient on NIV. So I'm giving advice while looking at the patient, and I'm saying, okay, this patient is deteriorating. Can you send your ambulance? This is the advice I'm giving to you. Or can you get this patient intubated by the anesthetist in your hospital? And every district hospital in India has operation theaters and they have anesthetists. So I think a retrieval system needs to be created. And this system will help both the systems, like the smaller hospital and the larger hospital. And this system, of course, involves a little bit of infrastructure, training, and as Dr. Pandit and Dr. Peter, they've been working with the National Task Force, and they've been putting all the ICUs of each state, if they can be put on a centralized database and classify them as tier 1, tier 2, and I'm sure all this is being done, but if it can be done in a more hastened way, and this way a small hospital, for example in Bede, a district hospital in Bede, who doesn't have a roster system for an anesthetist to intubate a sick patient, and a patient will die there just because he couldn't get intubated. So smaller hospitals just are not planned enough. So I think this first we need to classify the ICUs into various classes, put them into a centralized database, connect the smaller hospital to a larger hospital, create the infrastructure and technology. It could be just with advice, or it could be a proper retrieval system through ambulances. And ambulances are all there. We have the money. Ambulance is not a problem. It's the part that what kind of patient is being transferred. You just put a patient like this with a non-rebreather in the ambulance, that patient is going to die on the way. So those decisions, if those decisions can be done on the phone or looking at the patient, and I think the technology is there, people are there, all we just need to do is just to make it in a nice structured packaged fashion, which of course we don't do in Singapore because we don't need it. It's a very small country. But I think Australians are doing it, the Britishers are doing it, and the Americans have a very good tele-ICU system as well.
So it's a good way to utilize it
absolutely.
in order to reduce and also reduce the work burden onto tertiary care hospitals also. Okay, thank you, Monica. Over to you, Dr. Ray. How will you like to communicate? There have been a lot of relatives are sometimes unhappy that the hospitals don't inform us about the patient's condition because relatives are not allowed. So what do you think ideally should be the mode of communication? It should be in person, or it should have a WhatsApp call, or it should be a digital mode of communication? We have already seen that digital mode is the best way from the two speakers ahead of you. So how do you plan communication?
So coming to communication, there are two things in communication. First thing is the communication between the healthcare provider and the patient's relatives, that is the family, and the communication between the patient and the family. So although in the peak of the pandemic or during the first wave or second wave, there is a much more restrictive visitor policy. So most of the any visitors are not allowed. So with time also from international guidelines or whatever, we've learned that to have a strict policy or strict restrictive policy for visitors is not a good way. We can have a mixed policy where maybe not in the peak of the pandemic, but during the tail ends, you can allow some visitors at some certain points. But with our setup, the main problem is that first of all, there is a risk to the family member. First of all those things should be not for the social visitors rather than from some healthcare or volunteering or family members. And so the risk is to the family, risk to the other patients or healthcare workers, and also the logistic issues like availability of PPEs and use of resources. Those things are also concerned. So what we have done is that we have currently till now, most of the time we have a restrictive policy with communications with for the family from the healthcare group is like a team. It's a family medical communication team. Every day this communication team contact those family members or the contact details and communicate about the patients. Many times the patient demand for seeing the patients or those things. So with that, within the dedicated COVID area, we have some dedicated mobiles which we sometimes ask the nurse inside to have a video conference with them. But these things are not possible because it has a extra load on the nursing care, and also sometimes those things has to be supervised, or there is sometimes some privacy issue was also there. Giving a phone or giving a device to the patient is not an option, because most of the time there has been incidents that a lot of privacy issues are there because other people who are not that sick are videoing or sending images in from which are not good in terms of those things. With the current medical legal systems, we are not clarity enough which one is good. In the beginning, we also try to inform the ICMR regarding consenting over video for procedures, because at that time the relatives are also quarantined. So if you want to do a tracheostomy or something for consenting, at that time ICMR give up some directives that you can go ahead with that. But till now, we don't have any clear-cut medical legal policy from the government regarding these things. Second thing is that regarding the what policy should we adopt, I think it's a clear-cut restrictive visiting policy is not going to help us or the patients. Maybe in the peak of the pandemic, you can, or where the community transfer is much more higher, you can go ahead with it. But it should be individualized to the institute or the religion according to the prevalence of the infection at that center. So maybe some 1 or 2% can be allowed with a training. What we have done at the end with that, we have some videos for donning and doffing. We show to the patient's relative how to don and doff, and some basic instructions what to follow inside those area. And mainly also you should not allow the visitors for all the patients. There are certain risk of patients which are much more helpful, like much more prone for developing delirium or end of life care. So those things should be allowed for those things.
Thank you, Dr.
Subal.
Yes.
Subal, just give 1 minute to Monica also, because this is her subject and she is master in communication. So Monica, would you like to add something? Because I would like to listen to you, although because you spoke really very well.
Yeah.
But
No,
Monica is supposed to be teacher for the communication. For all of
No,
us.
I mean, I agree completely with Dr. Bikash Ranjan Ray that it has to be individualized based on what is presenting to your hospital, what kind of issues do you have in that region, security, regional, cultural, what are the expectations of that region, how do people normally behave in that region. So there are many issues, so there can't be one policy absolutely for even within the country. There are so many variations, but yes, if a hospital can avoid having 100% complete closure, that is definitely the right way to go. It is very emotionally disturbing not to be able to see your relative, but again there are practical issues in smaller centers all over the country which involve security and hitting of doctors, which therefore again it is ideal. And I think all bigger centers would have great visitation policies. That means they will allow some people to see and not all the time. So I think more about it's not only just visitation, the clarity of information which is being given, how it is being given, which can sometimes be given through video messages like WhatsApp. And if you are in a good resource center like a corporate, like the corporate world, you have the iPads and all those devices, and people can afford all those things. Those would be. But in a government setup, again, I think the content of the communication matters a lot for, and that is one of the problems of. It is not just visiting policy, which will have an effect. Yeah.
Thank you, Monica.
Thank you.
Over to you, Dr. Pratibha Dilip. We have seen the restrictive policies and the open. So what do you think? We should allow relatives to visit in the COVID ICUs or the COVID wards? What is your take on this? A lot of relatives come up that I've already been positive. Let me go and see my mom or dad.
I think we should allow, because it's very traumatic, especially for the patient who is conscious. It's very traumatic to not meet them. Sometimes, that causes more problem than COVID. So I think many of them, as I had said earlier also, that half the world is right now COVID positive and half of them are not. those who have already turned positive, they should be, in fact, that would take some burden off the medical fraternity. Because
Thank you.
half the time the problems are psychological, and the nurses are not having enough time. They are taking care of many patients. They are very tired. They can't remain all the time so nice to them. So if a family is around, at least for some time, it would really help a lot. Another one thing which I felt I should be talking here is that we should come up with something which is a reusable PPE kit for relatives, which is maybe some research should be done on that.
Subhan, if you
Yes.
permit me,
Silver impregnated or
from the government sector, I by and large, I agree with most of the comment, but we did something very different, and probably it may look very controversial. In fact, if you look at it, it's very theoretically very good what we are talking about, and I agree with Monica that social, cultural issues, religious issues become extremely important. Unfortunately, as a doctors, we don't put emphasis, and that is one of the major reasons of miscommunication and discord. I think we as a doctors, even now when we are talking today, probably we are talking all like a parrot in terms of, sorry for using that word, but we're coming out from the books or the journals. Let us stay in the real life. And here what we did it, we realized I don't have a nurse for 10 nurses, every 4 shift I have 1 nurse. How can I provide a care? People can't eat, people can't go to toilet, people can't do anything. Who is going to help them up? They're lying in their own muck. So I think we need to realize, we need to think about it. We allowed attendants to provide care in my intensive care against, I utilize my position as a state nodal officer. And trust me, we had the best outcomes. The best monitors are their attendants, best monitors. Therefore, I fully agree with Pratibha that we need to look at it. We are only talking about science, we forget the art component of medicine.
absolutely, I agree with you.
I think as important. And that is one of the major reasons of discord. I know Ashish will have a very strong view on it.
Yes, Dr. Balla is waiting to comment, give his comments.
Unless and until you are certain of your nursing, doctors provide treatment, nurses provide care, and it is the care component which is coming under the challenge. And that is where the communication is a strong component of your risk.
It has turned from care to scare.
Pardon?
It has come from care to scare.
Yeah,
it has become scare.
Absolutely.
Can I come in?
Yes,
Subha?
Dr. Balla. Yes, Dr. Balla, please.
Yeah,
Dr. Balla.
I admire what Dr. Dhruv says, and I respect him for everything. But what we kind of had a middle path. For all the children, we allowed the mother to stay in, because most of the time when the child is positive, the mother is likely to. For all the critically ill patients, we ask their family members to test themselves. And if they are positive, we'll admit one person with us so that this person can stay in a room upstairs and go visit him, take care of this patient in the ICU, wherever it is possible. We allowed that, although we were designated tertiary care hospital where no, normal person not requiring oxygen would be admitted, but we allowed that. That helped. But a lesson learned from this pandemic is
allow relatives.
We need too many doctors. We need more nurses. We need more trained nurses who will carry out the orders. A person sitting in the ICU at a separate place can pass on a relevant order which will help the patient, provided there is a nurse who's able to take care of that.
Thank you. Thank you, sir. In the interest of time, I'll have to cut short. We just move on to the last two questions. I would like Dr. Peter to comment upon the drug audit. Is it important, and whether it should be carried out, and then followed quickly by Rahul Pandit, who will be talking about the oxygen audit.
Audit for any hospital or healthcare organization is healthy, because you have a cycle of assessing appropriate use and healthcare delivery. So it is important. How we do it is left to each individual institution. But I think as time is short, I'm just going to stop with that to say audit is important. There are several ways of doing it, and it should be done even for COVID, particularly antibiotic use.
Yes, thank you, sir. That's
And
a very important
steroids.
message you have given. Rahul, can you just tell us in short about the oxygen audit? You've been appointed by the Supreme Court of India. Okay, what is the real plan in short? Can you just summarize it?
So look, I completely agree with Dr. Peter that audits are healthy, and with each of these waves, we are coming up with new terminologies. Right now, the new terminology is revenge tourism. So now one of the oxygen terminology is oxygen stewardship program. So we need to have oxygen stewardship program in each of the hospitals wherever we are using oxygen. We need to look at the oxygen targets. On evidence-based medicine, we need to revise the oxygen targets. We need to actually curtail the use to the optimum so that the patients are benefited, not harmed in either way. So too much of oxygen is bad, too less is also bad. And of course, at the state level and at the national level, you need to have policies where we need to extend this oxygen stewardship program to the state level by creating oxygen depots, by creating sub-centers. All of this has been discussed quite extensively. And at the national level, have oxygen stores. Just like we have a wartime store available for petroleum products for 2 or 3 weeks, we need to have oxygen store available for 2 or 3 weeks, because when the pandemic hits and the wave is really at the top of its curve, you are looking at the 2 or 3 weeks window where all of this will be required. So that's what you need to do. That depot should be there.
Thank you, Rahul. One last question to Dr. Jose Chaco. There have been continuous revision in the protocols as far as the drugs is concerned. So how do you keep your unit and give the message to all the team regarding the same? I request you please be short.
Yes, but COVID-19 has, of course, been a completely new disease, and we were devastated by it in a very short period of time. There's been a humongous volume of research that's been done with several drugs, many of them repurposed, some of them new ones as well. So just briefly, remdesivir was a focus of interest during the second wave, mainly because of the unscrupulous activities surrounding its use. So you need to, I think, specify when making a new guideline, you need to specify when are you going to use it, particularly considering the fact that it's not been associated with improved survival in any study so far. So you need to identify those subgroup of patients who might benefit from it. Chloroquine, hydroxychloroquine has been used even today, but there is a plethora of literature that establishes its non-efficacy in either prevention or cure of COVID-19. Ivermectin is another drug which we need to think again. A couple of studies, one Bangladeshi study combined with doxycycline had shown some benefit, but by and large, it doesn't really seem to help, and we perhaps need to relook at it and take it off from the routine use in many of our patients. There is no question that steroids in modest doses are helpful. Dexamethasone has been studied, hydrocortisone has also been studied. These would continue to be the center of attention and the mainstay of treatment in seriously ill patients. Inhaled budesonide has also been studied and found to be useful in patients with milder disease. So it's probably an important addition to patients who are less severely ill. Azithromycin alone or in combination, not being shown to be effective, we need to modify that as well. Tocilizumab, we've discussed previously as well. One of the drugs which may improve mortality, particularly with the REMAP-CAP trial and the recovery trial, which has shown benefits with its use. Anti-coagulation, the general consensus from the available literature is that apart from situations in which you strongly suspect clotting to be a problem, routine BVT prophylaxis will do, and you need not be over-aggressive. And of course, the new monoclonal antibodies against SARS-CoV-2, the combination of bamlanivimab plus etesevimab, as well as the combination of caricimab and imdevimab, which will probably come into use more often in the future in patients who are at high risk of severe illness, and also as a preventive measure in those who are exposed and who are at high risk of getting severe disease. So these are some of the things that we need to look at when we revise our treatment protocols for COVID in the future. Thanks, Siobhan.
Thank you very much. And last question, Dr. Balla, just quickly, can you just give a message about vaccination to everybody? Last quick question, answer in short.
I shouldn't be the person whom you should ask this question because, but
I'll say,
the thing is that we have nothing else with us. The only way we can attain immunity is by having mild infection or vaccination. But what I'm most concerned about is the safety of the vaccination. We need to have established safety of the vaccination. Efficacy, is to me the secondary part. And even with the newer strategy of giving a booster dose or mixing of vaccination, I think that has to be looked at far more carefully regarding the safety parameter first before we kind of jump on that.
yes. I agree. Thank you, Dr. Balla, and thank you all the faculties who have participated into this excellent contribution with the knowledge from this webinar for resource management and how you should prepare yourself for the third wave. I thank everybody again on behalf of ISCCM, and I request Dr. Govil and Dr. Rajesh Mishra to please take over.
Thank you, Dr. Dikshit. I would request Dr. Rajesh Mishra to please conclude and say vote of thanks.
So, it was really a very dry subject, but thank you, Suval, for preparing such a nice question, and everybody has taken up really nicely. It never looked that the subject is dry. So really we enjoyed listening to you, and thank you all for joining us. It will be a continuous process since this is going on very successfully, and this platform of ISCCM is being used by a lot many. So we are going to come with new excitement, new topic, and which will be useful for all of us. So thank you for joining us, and see you on next Sunday, same time.
Thanks, Rajesh.
Thank you, Rajesh. Thank you for the opportunity. Thank you so much. Thank you.